The Schrag and Lee abstracts were very timely in terms of filling in some blanks that 80405's analysis gave us. I'd have to admit that the Schrag abstract was one that I asked Deb to work on. I was the senior author on that abstract. When I saw our data, I thought, first things first, is this seen in the SEER database? Deb Schrag is a fabulous investigator who knows everything about everything. And she said, no, that's not, we're not going to see that. I said, humor me. And so she did a very wonderful analysis of the SEER database from 2002 to 2012. In fact, just as you might have expected, patients with left-sided primary live twice as long as patients with right-sided primary. These are Medicare patients. It's a different population. We don't get information on treatment for the most part. She did do an analysis. She was able to get some cetuximab data. All of their data makes it, although the numbers are different because it's an elderly population, all of the data is consistent with what we saw in 80405. It's a confirmatory observation in a broad population-based registry. Frankly, she was very surprised, as was I, that the result was that convincing. The MD Anderson paper, Michael Lee was a junior person. Really, the person behind it is Scott Kopetz, who's a really superb scientist at MD Anderson. Michael Lee has now moved to University of North Carolina. He worked with Scott. What he presented, basically in a very selected population of patients, not reflective of a real world, but what they see at MD Anderson, they very much saw, they were able to look at different biological features, molecular features of different cancer patients, and come up with an idea of who did what and what was responsible for better or worse outcomes. It was selected, they knew what they were looking for beforehand, but they showed it. In fact, they pretty much put together a molecular package that explains what the results are. Doesn't mean that is what they are, but it's consistent with it. So another very confirmatory bit of research that shows that things like amphiregulin, epiregulin, some of these cofactors are relevant in outcome. And then the other paper discussed was Dr. Kimi Ng, who was the discussant who put it in perspective, I thought, very well. We don't often in ASCO, in a colon cancer session, have three papers that put together a story, and that's kind of cool to be able to do that, to ask and answer the question all in the same session. And that's the collegial, collaborative nature of what we can do sometimes. That's good stuff. Clearly, it takes a lot of us to put together to figure this out. As I said, it's humbling for most of us to realize that I've been doing this for a long time, and I never realized that we had two different diseases on our hands. I was asked yesterday, was I going to be a right colon cancer doctor or a left colon cancer doctor? I chose left because they do better than right. But somebody else chose right because they need more help. In any case, it's a kind of an amazing development that none of us saw coming. The question, of course, I'm asked is, does this change what I'm going to do for my next patient? Probably not. I've known this data for a while, of course, so did I change a while ago? Maybe so. But I've never been a big user of cetuximab first line because most patients in the US really don't want the acne rash. I do believe that you need to pick and choose your patients carefully. We will probably be more aggressive in trying to get the molecular information earlier, but without question, a right-sided patient with right-sided tumor, I wouldn't give cetuximab now. I probably haven't done that mostly, but that would be a change. Otherwise, I don't think it changes much of what I do. For other practitioners, it may, and other people may look at the same data and come up with different conclusions.